you, Dr. Samya. So now I'll request Dr. Sreeni, Edakhlon, to talk on modification of glaucoma medications for Phaco emulsification.
Thank you, sir. Good afternoon, all. So when you are actually talking about initiation or modification of glaucoma medications for cataract surgery, these are the scenarios to be considered. Lens-induced glaucoma, postoperative glaucoma, ocular hypertensive or pseudo-scleration patients who are not on any anti-glaucoma medication, glaucoma patients well controlled on topical anti-glaucoma medications. The non-glaucoma patients, including high hypermetropes, those with crowded anterior chamber, hard cataracts, those with poor endothelial status also we have to consider. In lens-induced glaucoma, obviously the treatment is cataract surgery, but till the patient is taken up for cataract surgery, you have to give maximal medical therapy to control the intraocular pressure. And since prostaglandin analogs, because there is an inflammation component here, so since prostaglandin analogs take a bit longer to act and it can induce inflammation, it may be avoided in these cases. Similarly, in postoperative glaucoma, it might be a good idea to prostaglandin analogs, avoid prostaglandin analogs if it is possible. Coming to pseudoexfoliation, this study by Ken Hayashi et al. Have shown that oral acetazolamide administered 1 hour preoperatively and 3 hours postoperatively blunts that postoperative intraocular pressure spikes that happens after cataract surgery in pseudoexfoliation patients. So this is good and can, like carbonic anhydrase inhibitors, see it's supposed to act on the ion transport. But can it be used perioperatively in cataract surgery? This study has shown that carbonic anhydrase facilitates ion transport impacting corneal endothelial function in bovine, but not human corneal endothelium. So this finding supports the clinical observation of no corneal swelling in humans administered with the carbonic anhydrase inhibitors and suggests that an alternative ion transport mechanism may be operational in corneal endothelium in different species. So carbonic anhydrase inhibitors may be safely used. So those coming to those with hard cataract and poor endothelial status. So what anti-glaucoma medications to be used? These are anti-glaucoma medications, but it's been shown that ROCK inhibitor, rapazidone, shows an endothelial protective effect. Okay, so this study was done in two groups, 13 glaucoma patients and 13 controlled. It was seen that the mean rate of increase in the thinnest corneal thickness 1 week after cataract surgery was 1.25% in rapazidone group, which is significantly lower than the 5.97% increase observed in the control group. So the result suggests that rapazidone may help maintain the corneal endothelial function integrity and reduce cell loss after cataract surgery in patients with low corneal endothelial sensitivity, suggesting that it may be more broadly used for protection of corneal endothelium after cataract surgery. But when you're using these ROCK inhibitors, you have to consider this corneal honeycombing. So this is corneal honeycombing that happened with ROCK inhibitor. But the good thing about it is that it doesn't seem to affect vision and it disappears after stopping ROCK inhibitors. So small eyes, use of 100 ml 20% mannitol given half an hour to 1 hour prior to surgery effectively lowers intraocular pressure and increases anterior chamber depth. So it will be a good idea to give mannitol in these cases. So let's come to the other part. The effect of cataract surgery on eyes with glaucoma. We have to consider cystoid macular edema and the effect of cataract surgery on intraocular pressure. First, let's consider cystoid macular edema. It's been seen that cystoid macular edema is significantly greater in patients with primary open-angle glaucoma, and their risk is higher in patients using prostaglandin analogs. So this is the mechanism in which the cystoid macular edema occurs following cataract surgery. The surgical stress releases inflammatory mediators, transvitreally it goes and breaks the blood-retinal barrier and causes cystoid macular edema. But it is highly unlikely that these prostaglandin analogs directly influence the normal blood-aqueous barrier function. Rather, they may prolong the production of endogenous pro-inflammatory mediators produced by the lens epithelial cells after cataract surgery. But as you know, a lot of studies have shown that prostaglandin analogs can play a role in development of pseudophakic CME. So should we stop prostaglandin analogs after cataract surgery, for cataract surgery? See, all of your wonderful phaco surgeons, absolutely, and the modern phaco emulsification doesn't cause release of huge amount of prostaglandins. So should you actually stop? But another point is there. See, if you stop prostaglandin analogs, and IOP increases, the untreated elevated intraocular pressure itself is a risk factor for cystoid macular edema. So there has to be a balance. But consider, like we have decided to stop prostaglandin analysis. When do we stop it, and with what do we switch? See, pilocarpine is effective, acts very fast, but obviously it can't be used. Topical carbonic antihistamines, it's also very, very fast, but it's not strong enough to replace prostaglandin analogs. All others takes about 4 weeks. So if at all a switch is made, it has to be made 1 month before cataract surgery. Use brimonidine, it causes allergy. You want a quiet eye after cataract surgery. Timolol, you have to consider the systemic implications. And another factor is to be considered. See, stop prostaglandin analogs, how long is it going to stay back in the eye for it not to cause effect? So it's seen that the effect of prostaglandin analogs lasts about 4 weeks after stopping it. So based on this, prostaglandin analogs should be stopped 1 month before surgery. But this washout is for the IOP lowering effect, because of the remodeling that occurs in the ciliary muscles. And there is no direct evidence of prostaglandin analog persistence in eyes for a month with CME inducing effect. But it might be a good idea to wait 1 month if you're stopping prostaglandin analogs. There is another study which has shown that there is no statistically significant increase in risk of clinically significant macular edema with prostaglandin analogs. But this survey report has shown that it might be good to stop prostaglandin analogs because there is an increased risk of cystoid macular edema. So should we stop prostaglandin analog? Yes, if you're sure that you can control IOP with alternative anti-glaucoma medication. Yes, if you can wait 1 month for cataract surgery. Yes, if the patient is at higher risk of CME. So stop prostaglandin analog postoperatively in complicated cataract surgery. So effect on IOP, it's shown that cataract surgery itself lowers the IOP for about 4 millimeter, and its effect lasts longer. And the strongest predictor is a preoperative and higher intraocular pressure, the higher the drop. And studies have shown that you can reduce the anti-glaucoma medications. So can we drop it, reduce the anti-glaucoma medications? Yes, but it should be based on the level of postoperative IOP. So conclude, the perioperative intraocular pressure control is critical importance. Though IOP may drop post-cataract surgery, one should reduce anti-glaucoma medications postoperatively only after proper evaluation. Topical prostaglandin analogs, if the patient is at a higher risk of cystoid macular edema, stop it. ROCK inhibitors may be used for endothelial protection. Topical carbonic inhibitors can be used. And welcome you all to AIOC Kochi 2023. So please come. Thank you.
Thanks, Dr. Sreeni, for your excellent talk on what to do in those cases.